Thank you all so much for participating. My name is Daniel Underberg. I'm a PGY2 in internal medicine at Northwestern University in Chicago. The case that I'll be presenting today is pulmonary artery stenting as a treatment for severe stenosis caused by fibrosing mediastinitis. Sorry, okay. I have no disclosures. And the patient that we'll be talking about today is an 86-year-old woman with a history of severe COPD, vocal cord paralysis, and a calcified mediastinal mass who presented to our institution with acute on chronic dyspnea on exertion. Her initial evaluation was significant for CT angiography of the chest that demonstrated absent left pulmonary artery blood flow, as well as severe right pulmonary artery stenosis. It also showed severe dilation of the right PA proximal and distal to the stenosis and a large calcified mediastinal mass. These findings are often characteristic of fibrosing mediastinitis, in particular the calcified mediastinal mass. This concern for possible fibrosing mediastinitis versus a malignancy or another etiology of the compression of the PAs led to a bronchoscopy with biopsies of the calcified mass, and this revealed inflammatory changes concerning for fibrosing mediastinitis. So at this point, a multidisciplinary decision was made to pursue PA stenting as a treatment for severe PA flow limiting stenosis. The first step in the procedure was that a pigtail catheter was inserted into the main PA and was used to perform pulmonary angiography in order to provide a roadmap for intervention. The angiogram identified the area of stenosis with significant pre and post stenotic dilation. A pigtail catheter was exchanged over a 0.035-inch J-tipped wire, and a 6 French multi-purpose catheter was exchanged across the lesion in the right PA in order to assess its hemodynamic significance. And as you can see here, the initial right heart catheterization during the procedure revealed elevated right-sided pressures with a PA systolic pressure proximal to the lesion of 75, a PA systolic pressure distal to the lesion of 26, yielding a pressure gradient across the lesion of 50 millimeters of mercury. And this is the initial pulmonary angiogram pre-intervention where you can see that really tight lesion in the right pulmonary artery. So intravascular ultrasound imaging was performed for vessel sizing, and then over an Amplatz extra stiff wire, the predilation balloon was inflated, and this was in order to ensure lesion compliance. Predilation to the final size, however, was avoided in order to decrease the risk of stent migration in the setting of the pre and post stenotic dilation that was visualized. After serial dilation with a 5 by 60 millimeter Mustang balloon and then an 8 by 20 millimeter Evercross balloon, an Express LD 10 by 25 millimeter stent was deployed. And this is because of the excellent radial strength of the Express LD stent. And as you can see here, the post-intervention right heart catheterization showed a PA systolic pressure proximal to the lesion of 70 and distal to the lesion of 46, yielding a pressure gradient across the lesion of 24, so significantly improved from the pre-intervention gradient of 50. And this clip here just shows dilation of the stent in the right PA. What was really interesting about this case and what really makes it stand out, I think, is the fact that because of the completely occluded left PA during balloon inflation in the right PA around the time of the stent placement, the patient's systemic blood pressure dropped dramatically. And as you can see in the tracings here, the blue lines being the systemic blood pressure and the red lines being the PA pressure. During inflation of the balloon, the systemic blood pressure dropped significantly to the point where it was really only the PA, really only equivalent to the PA pressure. And what this really highlights is the importance of considering prophylactic or bailout hemodynamic support strategies in this specialized patient population where there is such significant bilateral vascular disease. Things to consider from this standpoint could be things like pressors, which were on hand during the case, a consideration of ECMO if it came to that, and also thinking about something like an RP impella, which in this patient, unfortunately, would not have been an option given the occlusion of the left PA. And this clip here shows the final post-intervention pulmonary angiogram after the stent was placed. And as you can see, the caliber of the lesion has significantly improved. So the patient did very well after the procedure. She initially required nasal cannula oxygen, but was quickly weaned off after the stent was placed. Her dyspnea as well as her functional status improved significantly, and these results were sustained on follow-up over 14 months after stent placement. She remained on baby aspirin as well as clopidogrel for 6 months after stent placement, and will remain on lifelong aspirin monotherapy. She had a repeat pulmonary angiogram and right heart catheterization performed 10 weeks after the intervention, and this revealed a continued and significant improvement in her pulmonary pressures, as well as a durable reduction in the gradient across the lesion. And you can see in this clip that the caliber of the stented area in the right PA was sustained on this repeat PA-gram. Her, just as a reminder, her pre-intervention PA pressure proximal to the lesion was 75 systolic with a gradient of 50. And after the intervention during this angiogram 10 weeks later, her gradient across the lesion was 20, showing sustained and durable improvement of that pressure gradient across the tight lesion. Her CT angiograms for surveillance at 11 months after the procedure additionally showed a widely patent stent. So this is a question that we are proposing just in the context of this case. According to the largest published series of patients who underwent vascular stenting for fibrosing mediastinitis, reintervention was required in 28% of subjects. Which vessel had the highest rate of reintervention? And the correct answer to this question is choice B, the SVC. According to Albers et al., which is this large amalgamation of patients who underwent stenting for fibrosing mediastinitis, 28% of patients who underwent vascular stenting experienced symptomatic recurrent obstruction necessitating reintervention. Among those who received an SVC stent, 54% required reintervention, and this is compared to 5% in PA stents and 25% in pulmonary vein stents. Moreover, the median time to presentation of symptomatic recurrent stenosis was 24.5 months among those who received an SVC stent, and this is compared with an overall median time to recurrence of 115 months. Patients receiving SVC stents also had a relatively high rate of multiple reinterventions, with almost 50% of them requiring more than one revision. Unfortunately, the authors were unable to identify any specific factors associated with the need for further revisions, including final stent diameter, percent of goal diameter, or complexity of stent placement, meaning multiple or bifurcating stents. And the IVC was actually not intervened upon in this study population. So our conclusions and learning points from this interesting case: fibrosing mediastinitis is a rare, life-threatening, infiltrative inflammatory condition that can lead to compression of thoracic structures and is most commonly associated with prior histoplasma infection in the United States. Globally, we can also see this related to prior tuberculosis infection, sarcoidosis, IgG4 related disease, as well as just idiopathic processes. Medical therapies are of limited utility, and surgical ones often have very high morbidity and mortality. Percutaneous PA stenting in patients with fibrosing mediastinitis may result in sustained improvement in pulmonary hypertension, increased vessel caliber, and symptom relief, and it is also associated with low rates of restenosis and reintervention. And so far, we're seeing this play out in our patient. And this is the first report of PA stenting for fibrosing mediastinitis in a patient greater than 80 years old, with completely absent blood flow in the contralateral PA, which increases the risk due to reduction of the patient's cardiac output during balloon inflation in the target PA. So this case really supports the safety and efficacy of PA stenting for severe PA compression caused by fibrosing mediastinitis, even in elderly patients with high PA gradients and significant bilateral vascular disease. So thank you all so much for listening.
Thank you. Good presentation.
Thanks.
So can I ask you a quick question? So what was this patient's, do you know what their ejection fraction was?
Their ejection fraction, I believe, was normal. I don't know the exact number.
Okay. And so one thing, and then the other thing I would think about would be, did you guys, and I kind of got cut out due to the internet connection, but did you guys IVIS at all? Like
yes.
Okay.
Perfect. Yes, we did do intravascular ultrasound just to make sure that we got the right stent size.
Perfect.
Great. Thanks so much, Dan. I have to say that is a extremely complex clinical situation. I've dealt with this both medically and interventionally. I have not dealt with this problem causing pulmonary artery narrowing and the need for a stent. We have run into it once in the pulmonary vein, as you kind of alluded to in your question, and a few times over a decade in the SVC, as you also alluded to. So this was definitely informative for me to see the last kind of final presentation of this that hopefully I won't be subject to running into in the future based on how complex it is.
Yes.
One issue that comes up first, I just wanted to start with a short discussion about the medical issues and how you made decisions. You alluded to this. There, in some ways, this kind of issue this patient was dealing with is something that we could translate a little bit to our acute PE population, where we sometimes run into folks who have, totally occluded lungs on one side, pulmonary artery on one side, high-grade disease on the other side, and they're coming in sick with symptomatic disease and high RV pressures, high PA pressures. Mm-hmm. And you mentioned some of those issues regarding potential mechanical support options and anticipating that. Given her age and her comorbidities, where do you guys come down on as whether that was going to be an option? I see Dr. Schemmel, who probably was leading the charge, is on the call as well. So please feel free to chime in.
Thank you. Age and comorbidities obviously have to play into decisions to place someone on VA ECMO is kind of our go-to for patients with acute RV failure in the setting of pulmonary embolism or decompensated chronic thromboembolic pulmonary hypertension disease. When it's an acute PE and you think you might be able to bridge them to recovery, we'll be a little bit more liberal in our placement of these devices. But certainly you have to take into the context. She was a fairly functional individual, referred from another institution, but 86 gives everybody pause. I've presented other coronary cases where people give pause at doing interventions, and I think that the activity, the age, their functional tolerance is really important to that. And then via ECMO is not going to be a bridge to anything other than the recovery. So you really have to set the expectations clearly up front.
That's great. Yeah, I will say that on our PE our ECMO guidelines for our team, I do cap out at age of 75. That being said, just to allude to your point, the oldest patient we have placed on was 86, suffering from an acute PE, it turns out, coincidentally. That I won't forget, for the reasons you mentioned, that we thought that we did have a chance to reverse the cause, despite the fact that our guidelines kind of in hospital tend to be a little more restrictive.
Yes, we have the same cutoffs as a general rule, but I think that PE is different than the decompensated heart failure patient that oftentimes we think of with ECMO.
The next thing I wanted to get into a little bit with some of the technical aspects around decision-making about ballooning and stenting, which I think probably there was a fair amount of thought put into this. And I think the specific thing that would go through a lot of interventionalists' mind out there are, how do we choose what stent to use in this particular location? We have extremely high-grade disease. You have an important branch point, the truncus arteriosus, coming off and going to the upper lobe right after you kind of come off the right main PA. And then you have what Dr. Underberg alluded to as potential post-stenotic dilatation even in the main PA into the interlobar artery. And you have various options though now. It's kind of a pretty broad toolbox, both in terms of self-expanding stents versus foot-expandable stents, which have different pros and cons, both in terms of length, radial strength, and positioning, and also covered versus non-covered options. So I'll take a step back and think about how you guys thought about that. I think that there would be probably some variability around those decisions out there.
Yeah, I think that we actually requested this particular stent to come in for this case, but we had talked about safety and durability. and radial strength. So, covered stent for safety. What if there's any type of hemorrhage? Do we need that? Could we get a good seal in this position, knowing there's pre and post-stenotic dilation or there'd be endo leak? We did have covered stents available. We were worried a little bit about radial strength of the covered stent. And so we wanted to go, and there's a lot of discussion about the balloon dilation up front. Could we learn anything based on the compliance during a low pressure inflation with an oversized balloon? Or did we need to see that it was compliant by actually going to a nominal or higher pressure with the peripheral balloon? So there was a lot of angst in the planning, and after each balloon, Dr. Jivan can attest, we do a balloon inflation and just kind of pause and wait for any coughing, any hemoptysis, look at her blood pressure. We had that arterial line to monitor. And so I think we were all very nervous about it, and knowing that she didn't have a surgical ballot option.
Yeah, of course, at 86, that would not be a good option. And in terms of covered stenting, a concern that arose in my mind was regarding, available lengths of covered stents and sizes for expansion and where you're going to end up. There's somebody who doesn't have a left lung. So taking out a right upper lobe is really kind of, it would not be a good option. Was that something you thought of, or did you have a planned size for a covered stent? Were there VBXs that would expand large enough and short enough that you think you could have nailed it? Or was a situation be going back to some old school ICAS that the larger ones don't come short enough in my experience? How did you guys handle that?
Yeah, we thought about growth of those stents as well. And in her case, I thought we had enough of a distal landing zone that we wouldn't obstruct the truncus anterior. But I have had other cases in the left primarily where we talked about our covered stents and whether or not we would block some of the segments to the upper lobe for another fibrosing mediastinitis case that we have. And so that does come into play. But I thought that we had a 10 millimeter diameter covered stent that was available should it come to that. Although I still struggle to think that it may or may not really seal that spot, knowing wouldn't be opposed except for in that stenotic segment.
Absolutely. And the last thing I'll ask, and I'd love to have everybody weigh in too, Dr. Edwards, et cetera, is what do we think about, or if there any utility at all to the, in a case like this, to some of these newer, venous specific stents? The PAs is kind of a unique vessel segment because although it's clearly an arterial segment, it's uniformly exposed to lower pressures than our general arterial circulation. We do have these, new venous-specific stents, or not that new anymore, some of them, but the Venovo and the Vici, and then Medtronic has the Artery stent coming out, which I haven't quite got my hands on yet. But what do we think about pros and cons there? I'm forgetting which one of those is a more open-celled option. They're obviously self-expanding stents. Shortest, I believe, is 40 millimeters, but you'd be committing to going down an interlobar artery. But there could be various pros and cons. I don't know, Matt, do you have any thoughts on that of how you might consider that type of option of a self-expanding stent, and then the venous versus more typical arterial option? I'm mainly bringing it up just because of the size matrix, because your landing zones are so large here.
Right. Yeah, no, you have a lot of landing zone, and I think that is the thing, is these venous stents are a little bit longer. And you got plenty of room to use one. It is a low pressure system, so I think you could get away with it. But I think the sizing was pretty good. And I think if you get the right sizing, you're going to have more tensile strength in those arterial stents, I believe, than the venous stents. So I think in the long run, I think an arterial stent, if you can get away with one in this scenario, might be a better option just for the long term. So.
Yeah, it's certainly an outstanding result. And how did you fight the impulse? You started off with a peak rate of 50. I think it was mentioned it came down to around 20. You've got this visual issue of these huge vessels, both pre and post your stenosis. You obviously had a lot of concerns about rupture. What was your kind of ability to, how did you know what was good enough and where to stop, which I think would be a big problem for a lot of folks who are dealing with this, Dan?
Yeah, I think there are two things that go into that. One of them was the safety of it, knowing her age and what kind of durability we're looking at, just being realistic. We weren't aiming for a perfect angiogram and a perfect gradient drop. The other thing that we have a fairly robust CTEP experience, and seeing that after the intervention, people will continue to to drop their pulmonary systolic pressure, not at the time of the intervention, but months later. So one of the striking things with her is her gradient remained essentially the same, but her pulmonary artery systolic pressure continued to drop into those months later, leading to a hopefully better functioning RV. And so that's what we hoped would come out of the case, is that she continued to realize hemodynamic benefit later on.
Absolutely. Yeah, I think it was beautifully done, well planned, super high risk, complex, and unique. No question about that. And I'll leave anybody with any final thoughts. If there's any other words of wisdom from Dr. Schimmel, Dr. Javan, anybody also, or Dr. Underberg, please feel free to chime in here.
No, I too, I just to echo what Dr. Jury said, great case, great outcome. How is the patient doing now? I'm assuming some time has passed.
Yeah, she's actually doing great. On her most recent clinic notes from last month with her PCP, still has sustained improvement in her dyspnea and functional capacity. And that was about 14 months out from her intervention.
Excellent.
So still doing well.
Excellent. Good job.
Thank you, Dan. Thank you, everybody, for having us.
Great. Thanks so much, everybody, for joining us, and we'll wrap this one up.
Great. Thanks so much, everyone.